I'm here with epidemiologist Bonny Specker from South Dakota State University, who is going to give us an update on everything that has been happening COVID over the last week, and also give us an update on bed availability in South Dakota. Bonny, what do you have for us today?
Well, I've heard a lot about bed availability recently, and I just wanted to go over some of that data that's available on the dashboard, and also why it's so confusing. And, and I also am confused, so I don't think I'm the only one out there. But this is an example of the ICU bed availability that you see on the Department of Health dashboard. And if you notice down at the bottom, they have on the dashboard that in order to calculate the percent of hospital beds, intensive care unit beds, and ventilators that are available, the Department of Health combines information from the Have Bed data system. This is actually a federal data system that hospitals input data on what their surge capacity is during an emergency or a disaster, which we are in right now with the pandemic. And then they combine that with the South Dakota electronic disease surveillance system that tracks how many of those beds are actually occupied. So that Have Bed gives you how many beds are there, and then the disease surveillance system lets you know how many of them are actually occupied. And this is from today, where they say that 12% of the ICU beds are COVID occupied. Now, I have been keeping track of this up until about the September 11th was the last one I entered. And I stopped including this or updating this information because it just became clear to me that I didn't understand what these data were saying or where it was coming from. And part of that has to do with that Have Bed data system, and I'll try to explain that a little bit further. Originally, I thought that they were always using this denominator, 350 beds. That was in a news release that came out of the state back in May. And I just wasn't sure what was going on and looked into this Have Bed a little bit closer. And here's part of the reason why I wasn't sure about it. If you looked at the data from July 1st, there were 68 patients that were actually hospitalized with COVID. And that dashboard said 6% of the ICU beds were occupied. Then you look all the way to September 23rd as an example, 192 hospitalized patients, 6% of the beds were occupied. So something in the denominator has to be changing. And there's a couple ways that you can see this. One is that the percentages of these patients that are actually hospitalized that are in the ICU may be different at these 3 points. And I was only tracking ICU beds, nothing else. They also have hospital beds and ventilators that they put on the dashboard. But then I thought, well, is there something else that's going on that's influencing these numbers? So in looking into it a little bit further, that Have Bed counts surge beds, surge capacity. And a surge bed is defined as additional inpatient beds that are not necessarily operational or staffed. An example of this is Brookings, which is licensed for 49 beds, but has the capability for up to 80 patient beds during a surge plan, in their surge plan. When are the beds counted? When is that data updated? Well, it can be reported more than once in any one day. So it can be varying from day to day what the denominator actually is. If a hospital decides that they can't use some of those surge beds, maybe it's a staffing issue, then they can get onto that data system and lower their number of surge beds, or maybe they've identified a place where they can put more beds, then they can up it. So it varies from, day to day. It could be varying. So it's really difficult to interpret that percentage. Here's an example. Brookings, this is the Brookings Health System surge capacity. It's their surge plan. So they have up to 80 beds, and they list here where those beds are. As I mentioned, they're licensed for 48, and they can handle 45 patients. So if they're asked, well, what is your surge capability today? Maybe they don't feel they can get the staff, it would be lower than that 80. If they can get the staff, it would be that they could take it up to the 80. So they enter that data into the system when there is a change in what they feel their surge capacity is. And we do, by the way, put that in the city threshold report on a weekly basis that the city posts. We have the surge capacity, or whether or not the health system feels that they can handle a possible increase in the number of cases. One thing that's also really important to consider, and I've mentioned this a couple times already, is that staffing in the surge plan is extremely important. COVID patients in the ICU do require specialized care 24 hours a day, and they will need to have pulmonologists and other critical care physicians. I did a quick count of those this morning, and there are 35 in Sioux Falls and Rapid City combined. So those 35 physicians need to handle all of the patients, at least in Sioux Falls and Rapid. There are also critical care physicians in Aberdeen, Mitchell, and Yankton, I think. But there's also a need for specialized nurses and also respiratory therapists if a patient's ventilated. And then you have to remember that there's non-COVID related illnesses as well that need to be managed. So staffing issues are going to become increasingly important. We've seen a lot of hospitalizations this past week, and as those hospitalizations increase and healthcare workers become ill, that's going to be a real strain on healthcare staffing. So we really need to do whatever we can to keep our healthcare workers safe. So please follow public health recommendations, socially distance, wear a mask to protect others when out in public, and practice good hygiene because lives may depend on it.